So let's move on. So first of all, there was a question of in today's presentation I have added some things that how the CPSP basically makes question. So what CPSP does, how do they make the question? So the first question was MELT type 1 for lateral condyle fracture is basically which type of Solder-Harris injuries. So Solder-Harris injuries, they are repeatedly tested. They are sometimes being tested in different forms. So the correct answer was Solder-Harris type 2. This picture will make you memorize this thing. So you will remember this picture and you won't forget this. So there was also one thing that 2 correlates with the 2. Type 2 is Solder-Harris type 1 and 1 correlates with 4. So the next thing is what CPSP has tested from this topic. So this thing is very important. What CPSP has tested from this topic. I have told that ossification centers are often tested. They ask which ossification center, appearance, and sometimes mostly they have asked appearance of ossification center. So there is a formula crito you must be remembering: capitulum, radial head, olecranon. So there is a formula for that. Complication and incidence. They like to know the complication of lateral condyle fracture. I must say you must read these complications from Bullett's and from Campbell as well. The next thing they like to ask, Mills type classification. The next thing, physical injuries classification, they like to ask. And I have another question in the next few slides. So what else they ask? Physical injury zone is often asked. That is very confusing. So I would say that physical injury zone must be done from Campbell. The next question, this was the next question. So if you see that what is the possible answer of this question, the answer is B, percutaneous reduction with pin fixation. 7-year-old boy, he has fall on outstretched hand, radial neck fracture. So radial neck question is repeatedly tested in exam, and what they mostly ask the treatment or the classification. So as we all know, what is the treatment? Treatment depends upon residual angulation. One treatment algorithm I have shared this: if the angulation is less than 30 degree, whether at presentation or whether after you manually reduce it, then immobilize without reduction. If the angulation is more than 30 degree, then perform close reduction. And if the angulation is more than 30 degree, close reduction has been performed but it has not been reduced, then we will go for percutaneous pinning, reduction and pinning. And if percutaneous reduction and pinning is also unsuccessful, then we will go for open reduction. This algorithm gives rise to many questions in CPSP, and they like to ask question about radial neck fractures in pediatrics. So radial neck fractures are Solder-Harris type 2. Wherever in pediatrics you see any fracture with which Solder-Harris type is mentioned, do memorize. For example, triplan, T-locks, and other fractures like this. So what CPSP has tested from this, they have tested treatment and angulation with reference to angulation of radial neck, and one time classification was also asked. So radial neck classification, radial head, that is also on the basis of angulation, it was also asked. Then there is another question. This question is basically, when you read the question, how to solve the question if the treatment is asked and the diagnosis is not mentioned. Then first you have to diagnose. 4-year boy, look at the age, then you look at the, he has been pulled by hand, and if you look at his hand, if you don't mind, 10 minutes. So if you look at his hand, 4-year-old boy, and he has been pulled by hand while falling on the floor, and this is basically nursemaid's elbow. So the answer is close reduction by supination. And what CPSP has tested, nursemaid's elbow question is often asked in the exam. This is the basis. You can read this explanation as well. They have asked the mechanism and the diagnosis and treatment. Sometimes they ask diagnosis of this particular injury. Then there was a question, elbow is reduced in 14-year-old boy after trauma, but post-reduction radiographs show incongruence of ulnohumeral joint. What is the most likely etiology? Basically, this question is about medial epicondyle fracture. If you see medial epicondyle, not often tested, but you must know the age group of medial epicondyle fracture and the operative indication. There are very few operative indications of medial epicondyle fracture, so you must remember. Absolute indications for operative treatment are irreducible incarceration of medial epicondyle in the joint and the rare open fracture. So basically this word irreducible incarceration, or as the question was in this, interposed medial epicondyle. And the age group is very important. Mostly it is 14 to 16 years. CPSP has not yet tested medial epicondyle fragment, but they may test. Then comes the flexion type supracondylar fracture in 10-year-old boy. What motor deficit associated? Basically, this question, what the examiner wants to ask in this question, he is basically asking what nerve is mostly involved in flexion type supracondylar fracture. So anterior, the answer to this question was ulnar nerve, but you must know what anterior atrocious nerve is involved most commonly with supracondylar humerus fracture, second most common radial, but with flexion type ulnar nerve. This topic, supracondylar fracture, you must have a good grip on it. CPSP has tested Gartline classification. They have tested some radiological signs. Fat pad sign, what is the significance of posterior fat pad sign, anterior fat pad sign? And then Bowman's angle has also been tested one time. And Bowman's angle has been tested in terms of which lines make Bowman's angle. And treatment, sometimes very simple question about the supracondylar fracture, and sometimes they ask question of pulseless hand. Even in my exam there was a question of pulseless hand after reduction. So I have shared one algorithm over here. So pulseless pink, pulseless pale hand, it is very important. It is important to memorize the algorithm of this. And what is the protocol? There, the protocol depends whether it's urgent, emergent, emergent, and vascular exploration. So what is urgent? If the pulseless, well perfused hand, then check the vascular status, good perfusion, admit for observation. If not well perfused, perform vascular exploration. Basically, this is close reduction percutaneous pinning. If the question is that patient is pulseless and pink, what will you do? You will do close reduction percutaneous pinning. The next question comes, patient is pulseless, patient is pink, or pulseless pale, close reduction has been performed, but there is no pulse. What will you do? Then pulseless, poorly perfused, and emergent CRPP with vascular exploration. So algorithm about pulseless pale and pulseless pink hand must be memorized. So it is written, I think better to have a concept from Orthobullets or Campbell. Then there was a question. This is a question about the fracture of pediatric population. What extent of angulation is acceptable in forearm fracture, in femur fracture, tibia fracture, and distal radius fracture? So as you can all see in this question, the deformity was 10 degree of dorsal angulation. So what was the answer? Remodeling will occur. Why remodeling will occur? Because although the fracture is a 10 degree dorsal angulation, but still there are most likely chances that remodeling will occur. But CPSP has tested acceptable angulation chart. It is very important in pediatric forearm fracture. It is written in Orthobullets. Mechanism of flexion with respect to age, fixation with respect to age. It is both are mentioned in the same table. Position of the cast with respect to location of forearm bone fracture. In attempt earlier than my attempt, there was a question if there is fracture of forearm, proximal forearm, then how will you apply the cast? Proximal in supination, middle है तो neutral में, and if it is distal then pronation. So the answer was supination. Then the next question, Montegia fracture. Montegia and Gilesi both are asked, but Montegia is mostly asked as when we compare to Gilesi. And Montegia acute or chronic both are asked. So Bedo classification is very important. And what they ask Montesia both of pediatric and adult variety. Bedo classification, what is the most common variety in pediatric and what is the most common variety in adult? It is different. So both adult and pediatric has been tested. Classification and incidence of type, it is written in Campbell. I have written over here. What is the position of cast with respect to classification? If there is Bedo type 1, flexion 110 degree. If Bedo type 2, then the flexion you keep on reducing the flexion. So it is written in ortho bullets. So CPSP have tested Montegia fracture, its classification with incidence, and what is the position of the casting. Then coming on to the next question, treatment of chronic Montegia fracture means the patient presents with chronic radial head dislocation and malunion of the ulna. What will you do? The treatment is written in Campbell. Now I have written 3 questions straight away. Colles fracture, Smith fracture. What is the apex of fracture? So see, in Colles the apex is volar, in Smith the apex is dorsal. And the next question was Smith fracture and how will you apply cast? So there is a table I will show in a while. So in Smith fracture you apply in dorsiflexion and supination position. Most common fracture in children, it is distal radius, and in adults it is phalanges. Fracture traverses physis and exits the epiphysis. You all must know Salter-Harris each type of fracture with reference to its definition, because they write a definition of a Salter-Harris type fracture and they ask what type of fracture it is. So this is a table. I have taken it from Gurki manual, and many times question from this table has been tested. What else CPSP has tested? Both fracture geometry, they ask about it. Diner-Fogg deformity, there was a question about what type Colles fracture is. The options were given and the correct option was Diner-Fogg deformity. Mechanism of both Colles and Smith fracture has been tested. Applying cast is very important. And then Salter-Harris fracture description in single line of each fracture. As I have asked you, this fracture, that fracture traverses physis and exits the epiphysis. So what type of fracture is this? They ask many different types of Salter-Harris variety with one definition. Most common Salter-Harris, this was tested in previous attempt. It is not Salter-Harris 1, it is Salter-Harris 2. And treatment of Salter-Harris fractures, they ask what can be managed with closed reduction, what can be managed with open, and the zones as well. So this is the variety. The question that was asked, it was about Salter-Harris type 3. The next question, although this question has not been tested in exam, but I want you to have a good grip on the questions that are somehow sports related, pediatric sports, because I have recently seen that CPSP wants to increase the number of sports questions. So the correct answer was rectus femoris. How you can find the correct answer in this? The correct answer can be found by this AIIS, anterior inferior iliac spine. So what structure is at that point? That is rectus femoris. And then how the other answers are wrong? Sartorius originates from anterior spiral iliac spine, long head of bicep femoris, gluteus minimus origin, iliopsoas origin. So the origin in the question was a clue to the answer. Most common complication after neck of femur fracture in pediatric population, AVN. So you must remember incidence of AVN with each type of neck of femur fracture in peds, Delbert classification and the incidence. It is very important and they often test it. Then this question, most common complication after scaphy fixation, or even if fixation is not written, the answer is avian. There is a misconception that it is chondrolysis. This question has been tested twice. 14-year male sustained non-displaced transcervical fracture after. Okay, so CPSP has in consecutive attempts they have tested a question where they give neck of femur fracture type 1 and they try to confuse you with the scaphy, and in options, answer option, they give both options, percutaneous pinning and screw as well. So try to localize whether they are asking about the scaphy or whether they are asking about the trans epiphyseal fracture. So how to differentiate? Look at the age. If the age is of scaphy, then think about scaphy and go for screw fixation, not for the percutaneous pinning. And then the answer is E. And how the other options are wrong, I have also written. Answer 1, surgical treatment within. So close reduction and screw fixation across the physis is an acceptable treatment form of surgical management. So this I have given you the incidence of avian, the incidence of non-union and the fracture. When we will discuss the adult trauma, I will tell you the neck of femur avian and non-union rates are also tested there, but in pediatrics they have mostly tested the avian rates. So I have written it that any one management of neck of femur or scaphy is always asked. Look at the age and look at the options given. Percutaneous pinning and screw sometimes are given together. So you must see if it is scaphy, go for the screw, and if it is neck, then both the options are correct. But when both the options are given, then it means that there is something wrong with the question, or you can say something tricky about the question. Then comes the next thing, treatment table with respect to age. So as I have given you this table, I also want you to memorize the femur fracture, shaft of femur fracture treatment with respect to age. So the question is next one, but I have given you this treatment. So the next question was with respect to image, and you first of all you must know what is the type. This is type 2 shoulder Harris Thurston Holland fragment is visible, and the answer is C. Physical growth disturbance is likely possibility, and close clinical observation will be observed, because we know that it will go in deformity, but we can't decide the treatment right now. We will only do the close observation. And but CPSP has tested distal femur fracture with Salter as type injury, and classification has been tested in treatment. Now the triplane fracture, T-Lox fracture, very important, very favorite of CPSP. Triplane fracture, basically it is Salter Harris 4, but it is in epiradiograph it is Salter Harris 3 and lateral radiograph Salter Harris 2. So must remember, I told you any fracture with Salter Harris association must be remembered. Mechanism of injury is same, supination external rotation, similar to T-Lox fracture. There are two different types, lateral triplane, medial triplane. So mechanism in triplane is 2, in T-Lox it is only 1. So T-Lox fracture, the mechanism is regarding T-Lox and triplane. I would say you must have a strong grip on these two types. CPSP often asks the question. So the answer is A, anterior inferior tibiofibular. There is avulsion of that. And look at this treatment. If it is less than 2 mm displaced, then go for casting. More than 2 mm, then go for ORIF. CPSP likes to test transient synovitis, osteomyelitis, septic arthritis, TB, rheumatoid arthritis. So have a good grip of, on this. How to differentiate this question of transient synovitis from septic arthritis? Because there is mild to moderate restriction of the hem and WBC are slightly elevated. So the answer was transient synovitis, and this is a table. This is a very good table. I don't remember from where I took it, but it is a very good table to differentiate between transient synovitis and septic arthritis apart from the Cocker's criteria. And then this question. Look at this question. So the answer is Pseudomonas. Always the heel, foot, nail injuries, puncture wounds of the foot, they are associated with Pseudomonas. And organism causing osteomyelitis and sickle cell anemia, this question has been almost 3 times tested and the answer is salmonella. At the end, I want to show you this table, 22.1 from Campbell. Try to memorize this table, especially this part, initial part. And you must know that this is about arthritis, septic arthritis, and not osteomyelitis. So the organism for osteomyelitis is different from septic arthritis. Less than 2 years, Haemophilus influenza, neonate, staph aureus, more than 2 years, staph aureus. So group B streptococcus is for osteomyelitis and staph aureus is for septic arthritis. So that's all from the MCQ second test. I have tried to tell you how CPSP has tested each topic, and question about organism often asked. There are 2 to 3 questions about investigation, location. For example, sickle cell anemia, sickle cell arthritis is at which location? Diaphyseal location. Synovial fluid chart is very important. Repeated question about TB, sepsis, and treatment. So this was all from the second test. I know my speed was a bit fast, but I tried to cover everything and tell you how CPSP has tested each topic. We know to have knowledge from each topic, and we do not need to have the depth of each topic. We must know something about the each topic, and we must know every topic. So if you have any question, you can message me now or you can message me later on. I have tried to cover every thing from the topics I have tested in today's test. Mostly I have tested pediatric trauma. I know that many things in peds are left. We will decide whether to conduct the third test from pediatric orthopedics as well or not. So you people can tell me if you want to know something about these questions. You are all welcome. You are welcome, Misam. So we will keep on doing such things. Try to focus that what CPSP has asked and how they ask. So this is what I am trying to do. I don't want to engage all of you in questions that are too difficult and they're not tested. But I do not want you to go away. And one thing I am going to tell that is very confidential, but I am going to tell you that CPSP right now till October attempt, I do not know about the next attempt.